Get it out. See, I'm not that clueless.
So then this way Sharon can download it.
Okay. Let me get back to where I was. Okay.
Can't hear you.
The recording started.
Yes.
All right. Good evening, everyone. Thank you for joining us. We have an exciting topic for you today. We have brought back Moore to continue with telling us more about some of the issues that affect the heart. This particular topic that we're going to talk about today is afibrillation. It's an important topic that we don't hear much about, and we really should. You might be familiar with the commercial, the beat goes on when they talk about the medication for it, but this is an actual it can be a serious problem, which can lead to other heart-related issues, which can then cause potentially death. The reason why I asked about this to discuss this topic in particular is this is one of the health ailments that my mother was initially diagnosed with, which started the decline of all of her other health issues. It started with having afibrillation. So I thought it would be a good topic to bring to others so that we can realize it's not just a simple skip beat of your heart, but it could, if not controlled properly, cause heart damage, which causes heart disease, which causes other things to fail as well as it did with my mother. So I wanted this topic for us to talk about it, to put it out there, and I'm just giving you a little personal reason why we have this topic. So Dee, we are so grateful to have you back with us again. So if you could just, for the people who may have not joined us on our previous session, when we were talking about hypertension, can you introduce yourself and give a little background about you?
Okay. For those who don't know me, I'm Pearl's daughter. I've been a cardiovascular nurse practitioner for about since 1998. So almost 25 years, right? I've been a nurse for about 30, long time, all in cardiology. Cardiac surgery is my main focus. Currently, I work at Morristown Medical Center at the Channing T. Mass Center for Hypertrophic Cardiomyopathy. It took me a year to be able to say that without taking a breath. Essentially, that's for the young kids that you notice who are in sports, and next thing you know, they collapse, let's say on the basketball court, right? You remember recently there was a basketball player who was on the basketball court and then collapsed. So I take care of those types, the athletes, the young kids, their families, because HCM is genetic, and sometimes the first symptom is a cardiac event where you have cardiac arrest. And that's my current thing that what I'm doing. But today we're going to talk about atrial fibrillation. And so I'm very casual. If you want to ask questions, feel free to jump in and ask away. Very casual here. Okay. Now, so I wanted to talk about AFib. It is a global problem. And in 2010, it was discovered that 33.5 million people have atrial fibrillation, and it's projected that it's on the rise. Baby boomers are getting older, and there's a lot of them. So by 2050, there's going to be 5.6 million people who have this condition, so to speak. So it's only going up. It occurs more in men than women. For once, it occurs in white people as opposed to blacks over the age of 50, and highest in our continent. And of course, as you get older, your risk of getting AFib increases. Okay, so it is usually associated with underlying heart disease. I know that someone spoke about their mom having AFib, and that was the start. But AFib is usually is a hint that there's other things that are going on. So if someone has atrial fibrillation, they should be looking at other issues like heart disease, obstructive sleep apnea. And we're going to talk about some of those things further along in the presentation. But some of the other things that you could also see is atrial enlargement. And we're going to talk about the chambers of the heart. We're going to do a brief thing of physiology. I know for some of you, anatomy and physiology was years ago, but we're going to dust off that knowledge, and hopefully you'll be able to understand when I show you what we're talking about when we talk about atrial fibrillation. Now, some of the diseases that are associated with atrial fibrillation, because again, I said that AFib is associated with the underlying problem. Some of these underlying problems that could cause atrial fibrillation is high blood pressure, heart disease, and we're talking heart disease that will ultimately lead to heart attacks, valve issues, like if you have a leaky mitral valve. And if you're wondering what the mitral valve is, that's the valve between the left atria and the left ventricle. You guys remember the heart has the top chambers of the atrius and the bottom chambers of the ventricles. You remember that, right? Well, the valve,
put it like that.
No, it's fully charged, but you don't need to keep it.
now, heart failure is one of the things that's also associated with
Depending where you want to move it.
AFib. Tell Daddy to be quiet. Hypertrophic cardiomyopathy and heart disease that's inherited. You hear me? Other issues are if you have obstructive sleep apnea and it's untreated, diabetes, if you're obese, or if you have some kidney disease, that too can cause some atrial fibrillation. And one of the first signs, again, as I was telling you, was AFib will present first, and then you discover there's a whole plethora of other problems. Here are some of the reversible causes of atrial fibrillation. If you have surgery or hyperthyroidism. Now, what hyperthyroidism, we all have a thyroid gland, it's in our neck, right? The thyroid gland is responsible for metabolism. It's a wonderful gland. It helps with weight loss. If you're hyperthyroidism, you have hyperthyroidism, you're thin because your metabolism speeds up because you have too high of a levels of thyroxine, which is one of the thyroid hormones, which is one of the hormones that involved in metabolism. So for women, we kind of like that because we're thin. The only unfortunate thing, it causes dry skin and it causes hair thinning too. The hair thinning is not a good look for women, of course, as you know. But that speeding of the metabolism can cause a fast heart rate and atrial fibrillation. Another reversible cause is low magnesium levels, too much alcohol, too much caffeine. I don't know all you guys, but if you go to Starbucks, Starbucks is like jet fuel for caffeine. So if you have too much Starbucks in one day, you might notice some palpitations or atrial fibrillation, which is a rapid fast rate. And I'm going to show you what it looks like further along in the slide. And believe it or not, air pollution. So if you live in a place where there's a lot of air pollution, you have the risk from poor air quality of having atrial fibrillation as well. Any questions so far? We're good, right? Awesome. All right, so let's talk about the heart. See that? I tried to find a simple diagram to show. So don't let all those labeling things get you intimidated. Essentially, what I want you to look at is the normal chambers of the heart. And we're gonna go through this a little briefly. We have the top chambers. Here's the left atrium, the left ventricle. So blood comes from the lungs, goes into the left atrium, which is the top, one of the top chambers. Your left atrium contracts and blood goes from the left atrium into this left ventricle. The left ventricle then contracts and goes through this valve here, and it goes through the aorta out the entire body. Then it returns this way and it goes into the right atrium. This is called the tricuspid valve here, and the right atrium contracts, and then the blood goes into the right ventricle. This is the pulmonic artery. It opens when the right ventricle contracts, and blood then goes to the lungs. You with me so far? This is a coordinated effort. The top chambers of the left atrium and the right atrium contract simultaneously, push blood into the ventricles. That's what a regular rhythm looks like. And I'm going to show you what the EKG looks like on the next slide. But before we do that, I want to just illustrate what atrial fibrillation looks like. Now, the heart has a normal pacemaker. It's called the sinus atrial node. It's called the SA node. That stimulates the heart to beat at between 60 to 100 beats per minute. That's the normal heart rate, or the normal pulse, 60 to 100. Anything more than that, you have considered a fast rate. And atrial fibrillation is not the SA node or the normal natural pacemaker of the heart that's stimulating the heart to beat. It's these other cells that are in the atriums that decide it wants to take over and take control, and they shoot electrical pulses much faster than the normal pacemaker of the heart. And then you have patients who come with atrial fibrillation because it's irregular. The atrias don't know which electrical impulses to listen to. The normal pacemaker of the heart, the sinus atrial node, or these little cells who want to take over, and then you have irregularities, and the ventricle, and you have the atria start to quiver because they're listening to everything. Instead of contracting once and being done, they're just quivering. That makes sense? And when the atrias quiver, the blood can't go from the atrias to the ventricle. So then the blood has to just fall in naturally, and that's where clots tend to occur. Does that all make sense what I'm saying? Which is why patients with atrial fibrillation have to have anticoagulation to prevent clots from occurring, which can cause a plethora of problems. So going back to what a regular rhythm looks like, this is what your EKG should look like. Now I'm going to explain this. This is a sinus rhythm beat. This is one heartbeat. And this is what we look at on your EKG. This first little bump here is called the P wave. See this in pink, Q color. That's when the atrias contract. The left and right atrias contract simultaneously. You get this beautiful P wave. You see that? Then the blood goes from the atrias into the ventricles, and then the ventricles contract, and you see this huge wave. This whole complex here is called the Qrs complex. That's the ventricles contracting. It's normal. You want to see it upwardly deflected. Then you have where the ventricles reset themselves, and you have what's called the T wave in like this bluish purple color. That's a T wave. And it should be upwardly deflected. This is normal. The problem when it's downwardly deflected means you have an element of heart disease. But this is what a normal pulse heartbeat should look like. And so on your EKG, looks like this. Isn't it beautiful? So you have the little P wave, you have the QRS, and you have the T. P wave, QRS, and then you have a T. Do you see that in all these leads here? P wave, QRS, and you have a T. This T wave is a little downwardly deflected, but then it's a nice little rise here. This is what a 12 lead EKG looks like. Any questions on that so far?
So this is basically what your normal heart rate should be.
Correct. And it should be between the range of 60 to 100 beats per minute. In the cases where your heart rate is below 60 is if you're one of those conditioned athletes, because their heart rates are below 60 because they're conditioned. You know, their hearts have a whole bunch of cardiovascular endurance, and it doesn't have to beat between 60 to 100 to get the work done. So this is what it should look like. Now here we have atrial fibrillation. Remember I told you in atrial fibrillation, the top chambers are quivering. So you see, you do not see any P waves here. All you see is the little quiver waves. And it looks like, you know, someone's trying to draw a busted smile. But you do have these QRS complexes. This is when the ventricles contract. And notice it's irregular. And in a normal rhythm, your heart beats regularly. In atrial fibrillation, the hallmark is the pulse is irregular. The heart rate is irregular. And on EKG, you see it's not happening equally at the same time. It's all over the place. Now, rapid atrial fibrillation is obviously someone who's in atrial fibrillation and the heart rate's greater than 100. There are some patients whose AFib is controlled, and we call that controlled rate atrial fibrillation. Any questions on that so far? We doing good? We doing good?
Yes.
Awesome. Now, there's different types of AFib, but don't get hung up on that. There's paroxysmal atrial fibrillation, and that's someone who has AFib, but it stops within 7 days of onset. If it lasts for more than 7 days, it's considered persistent. And if it lasts more than a year, you've got long-standing persistent. And then there's those who live with atrial fibrillation, you know, which is, for some people, it's normal. They live with it, and then they are on medications to make sure it stays controlled or on a blood thinner. And then there's a term that I didn't put in here that's called subclinical atrial fibrillation. It's for those patients who have AFib and they don't even know it. And that's dangerous, especially if you're not on a blood thinner, because you run the risk of developing a clot, which could cause a heart attack, a stroke. You can clot off an organ. I've had patients who clotted off a kidney, a section of their liver. They can get a clot in their leg. The clot can go anywhere in their body, which is an issue. All right, some of the symptoms of AFib. palpitation of those butterflies in your chest. You feel like your heart's doing a polka in your chest. They're tired, they're weak. They might be lightheaded and dizzy. And you notice you're more short of breath, like just to leave the house and get to the driveway to your car, you might notice you're short of breath, which you wouldn't ordinarily have been. Shortness of breath going up inclines and stairs. You may even have chest pain or feel like you're going to pass out. Or you might notice you've got some swelling in your ankles or your belly swollen, or a combination of the two.
What causes the belly swelling?
Usually that's a sign of right-sided heart failure, with which you have the belly swelling and the swelling in your feet and your legs. Left-sided heart failure is when it's all in your lungs. And to explain that, remember, blood goes from the left side of the heart to the body. So if the right side is not doing its job in getting the blood to the lungs, you're going to create what I call a traffic jam. Blood is slowly going to get to the right side of the heart because the right side is failing and is not able to provide forward flow to that, getting that blood to the lungs. And so what you have is traffic. Blood tends to pool and get congested, and you have that swelling in the belly. You got the swelling in the feet. That's right side of heart failure, if that makes sense. Left side of heart failure, the right side of the heart is fine in getting the blood to the lungs, but once the blood goes to the lungs, it's slowly getting to the left side of the heart because the left side of the heart's not contracting as strongly as it's supposed to get the blood through the body. And as a result, blood fills in the lungs. And, you know, people have that pink frothy phlegm. They sound like they're drowning in their secretions and they're profoundly short of breath. You don't see as much swelling. You see more of the fluids in the lungs. That makes sense?
Mm-hmm. Mm-hmm.
All right, perfect. So the treatment options for atrial fibrillation, if you have a patient who comes into the emergency room who's having symptoms and they put them on the monitor and they see that the patient has atrial fibrillation, immediately then you don't know how long the patient's been in that rhythm. So the goal is, especially if their heart rate is greater than 100, is to do what we call rate control. Get their heart rate down to 60 to 100 beats per minute. We do not want to convert them because they could have a clot for all we know. So we give them something called a calcium channel blocker, like a cardizem infusion, just to slow the heart rate down. And then we put them on a heparin infusion, which is an IV blood thinner, to get their blood thin, because we want to try and eliminate any clots that the patient may or may not have. If they are stable, once we do those things, we will discharge them on a blood thinner, have them come back, say, in 4 to 6 weeks, and we perform something called the transesophageal echo, where you put a probe into, like a camera, into their mouth, into their esophagus, so you can take a look, an ultrasound at the back of their heart, as well as something called the left atrial appendage. You're looking for a clot inside the heart. If you don't see any clot inside the heart, then we take the paddles and we shock them. Although they don't use paddles anymore, they use pads now. You know, we got all sophisticated now, but they get an electrical shock to convert them back to a regular rhythm, and they stay on that blood thinner. But also too, during that time, you're also trying to figure out what the underlying cause is for these particular patients. If they are middle-aged, and I say the late 40s and up, they will start initially to work them up for coronary artery disease. You're doing lab work as part of their admission. So you're looking at their kidney function. You're looking at their weight to see if they're obese. Also asking if they snore at home, because snoring is a sign of obstructive sleep apnea, and untreated obstructive sleep apnea can certainly cause atrial fibrillation. You're looking for hyperthyroidism, so you're checking their thyroid levels to make sure their metabolism is not too high. Again, if they had hyperthyroidism, I doubt if they would be plump, because that makes you so thin. And they're looking for lung disease. And depending on what they find, they will address that issue and deal accordingly. Everybody with me so far, right?
Okay.
And then look for structural heart disease as well. Someone had a question?
No, I was just thinking back at some of the symptoms and then what came next after this. Because when she was initially diagnosed with this, she had a very difficult time sweeping the floor. She was just extremely lazy. We were like, why are you being lazy? But she just probably was not feeling well because she was out of breath.
Yeah, she was short of breath. She might have had heart disease. Did they ever find out she had heart disease?
Yes, she did.
There you go. That's where the AFib came from. And did they do stent, open heart surgery?
No, they didn't do any of those things. They basically at the point of when the heart disease was diagnosed.
Mhm.
She was already in her 70s, and
Okay.
they didn't really do anything.
Well, did she have heart failure at that point? Is that what it was?
She was entering heart failure.
Ah, okay. All right. And they just had to figure out what kind of heart failure she had.
Right.
Gotcha. Yeah, you know, I find that for our people, they're not as aggressive compared to, you know, non-African Americans. They're a little more aggressive, you know.
Mm-hmm.
Yeah, and also too now we have a lot more men at our disposal compared to back in the day. You only had a diuretic, digoxin, and an ACE inhibitor, and that was it. Now we've got all kind of tools and toys to prolong life for those in heart failure. But for those patients who you address their underlying issues, you get their underlying issues stable, and they still persist with atrial fibrillation, sometimes you need to do more invasive options like AFib ablation, where they take you to the cath lab, put a catheter in your groin, and what they do is they look for those cells in your atrium that are causing those electrical stimuli, and they burn them. Called cryoablation. They try and kill those cells so that you don't have atrial fibrillation anymore. But the problem is you're going through the groin. There's now this new procedure called a convergence procedure, where the electrophysiologist, we call him the electricity doctor, he's the one who looks at and takes care of people in their heart rhythms. That's what they do. They merge and they team up with open heart surgeons, a thoracic surgeon, and they cut open your chest, spread your ribs, and that way they can see better. So it's more of an open procedure where the electrophysiologist, the doctor who's burning those electrical cells, has a better field because the chest is open. That's called the convergence procedure.
I don't know if I want you opening my chest.
Yeah, opening the chest.
Oh, God.
Okay, I'm doing the talk. Okay, we gotta go. Say hi to everybody. Keep going. There you go. Hello. There you go. No, and then also too, there's something called the SA node ablation, where you just break down the heart altogether. Okay. And you just destroy everything. So you burn the SA node, and then you allow the patient to be pacemaker dependent. And
But doesn't that cause complications too if you're
Well,
fully dependent upon the pacemaker?
Well, you hope and pray the pacemaker always works. Because when the pacemaker doesn't work, you don't have a rhythm. And the SA node ablation is like the last, let me say one more time, last resort, because you are destroying the normal natural pacemaker of the heart. And sometimes that doesn't even always work. I've had patients who we've tried everything, and because in hypertrophic cardiomyopathy, AFib can be common. And once these patients go into atrial fibrillation, it's difficult to keep them in a regular rhythm. And I've had where they've tried all that. 4 atrial fibrillation ablations, 1 convergence procedure, because you're not going to do that. That's you only do once. And they still had issues with atrial fibrillation, and then we just destroyed their normal natural pacemaker. We will put a pacemaker in them first, of course, make sure it works. And we destroyed their pacemaker, and then they're pacemaker dependent. The only concerns I have is when you need to change the battery. I'm not really sure how they do that because they always need to be paced. So I guess they get a wire through here, and then you pace them like a temporary pacemaker as you change the battery in their old pacemaker.
How long does the batteries for pacemakers last?
About 5 years when you're dependent on it, 3 to 5. It'll last 8 years if you don't use it that often. Interesting, right?
Wow. Yeah.
Yeah, well, you don't really want to do that too much, for sure. Go away. And then there's those patients who do not tolerate anticoagulation, and those people who bleed, like those who have the what we call arterial venous malformations in their gut, for those who have aortic stenosis, or those who just have ulcers and they tend to bleed. A lot of times you're giving them anticoagulants, and the hemoglobin stays stable. It continues to drop no matter how low you try to drop their blood thinning agents. You can only drop their blood thinning agents for so low before you run the risk of them developing clots. So, but now we have something called Watchman procedure, and that has shown to have some promise. I think I do have. Hold on, let me see if I can do this. I do have something I want to show you on that. Here it is. Can everybody see that?
This is the Watchman Implant.
60
A
seconds.
one-time procedure to reduce your stroke risk.
We don't see the video.
You don't see it?
Blood clots most commonly
Hold
form
on.
in a
Hold on. Aren't I sharing?
We hear it, but we don't see it. So it depends. You have to probably share your full screen, or also share that.
I shared a full screen. It is the full screen. Hold on, let me see if I can do it this way. There you go. Can you see it now?
No, we still see your presentation.
Oh, well, let me get rid of my presentation. Now can you see it?
We see you.
Oh, the share window was closed. Ah, killing me. All right, hold on. I got it now. Share. Now can you see it?
There you go.
That's it. I got it.
This
I got
is
it.
the Watchman Implant, a one-time procedure that may reduce your stroke risk for a lifetime. In people with atrial fibrillation, blood clots most commonly form in a part of the heart called the left atrial appendage, or LAA. If a clot escapes, it can cut off the blood supply to the brain, causing a stroke. Closing the left atrial appendage is an effective way to reduce stroke risk in people with AFib, not caused by heart valve problems. Watchman is the only implant approved by the FDA to do exactly this. Watchman can be a life-changing alternative to the daily use of blood thinners and the bleeding risks that come with them. Talk to your cardiologist so you fully understand all the benefits and risks of Watchman. See if Watchman is right for you. Learn more at watchman.com.
Okay. So, any questions?
So I guess with now I think I understand a little bit more. AFib is really just a symptom of something deeper.
Mm-hmm.
So they didn't recognize the deeper yet. They saw that first, and then okay.
Well, I'm sure your mother probably had shortness of breath, and it was slow and insidious in onset. And because it was slow and insidious in onset, a lot of times patients don't realize how reduced their exercise capacity is until someone else makes a comment about it. Or they really can't do anything. Like, they get up, they do some housework, and they're like, "Ooh, I got to sit down."
Mm-hmm. Yep,
Get up,
that's
do some
exactly
more.
what.
"Ooh, I got to sit down." And how come I didn't? And then before you know it, they've noticed they done sat down 4 or 5 times that day, and they didn't get much done. And it's only then that they realize, I really need to go see somebody about that. And in your mother's case, I don't know if she realized until she came to see you and you guys realized this is a problem.
Mm-hmm.
Yeah.
Okay.
But by then she already had some pronounced heart failure.
Yep.
Yeah. And at 70, you're not eligible for a transplant.
Mm-hmm.
And I don't think at that time they had what we call destination therapy, like left ventricular assist devices for destination therapy. We have that now, but we didn't have that. Nope. Miss Allen, you got your hand raised. What's up?
My question is, what can we do, especially as African Americans, and I think it's more prevalent in women, what can we do that's preventative?
Well, actually, atrial fibrillation is more prevalent in men than women. But I think what we can do is, one of the things that we don't do is we don't go to the doctor. An annual physical can go a long way. We need to get to our underlying issues. In our people, we have well-known issues with high blood pressure. We have the headache. We make excuses of why we have headaches, and we just go lay down, take a Tylenol. We lay down, we wait for the headache to go away, then we get up and keep moving. What we need to do is encourage our people that it's okay to go to the health care provider. But what also would be nice is if we had more African-American healthcare providers. I think we'd be more comfortable going to our own than going to some of these non-African-American providers, because we all know it's in the news now about the healthcare disparities that are out there. When we go to healthcare providers that are non-African-American, they treat us differently. And this has been showcased for years. I think when I did a brief stint in PhD school, it was big. Healthcare disparities and some of the things they came up with, going to the barbershop, going to the hair salons to try and get screenings done there. They had good intentions, but it quickly sputtered, right? Nothing has really taken a dent in making sure that our healthcare is improved at all. So I think what we need to do is encourage our people to get educated, become healthcare providers. The more of us that are out there taking care of our own people and doing it well, I think the better off we'll be. But also, too, we need to be our own best advocate. If that doesn't happen, we need the tools with which to charter our own healthcare is what we can do in the interim until that does happen. Knowledge is power. Educate yourself. The internet, wide vehicle.
I believe that so much that if we know more, we can do better. When you know better, you do better.
Yeah, you
which
tell
is
the
one of the
doctor,
reasons
you're going
why.
to treat me. And this is what you're going to do. You know, you're not going to poo-poo me and say, "Oh, you're fine." No, I'm not fine. This is what I have. But we need to start with.
We need to educate ourselves.
Get insurance. Go to the healthcare provider. An annual physical. When you go for your annual physical, they'll find out if you have hyperthyroidism, because they're going to part of your blood work is a thyroid stimulating hormone level that they check for that. If you go there and your blood pressure is high, they're going to tell you to come back because they're going to treat you. And then on my high blood pressure one, calcium channel blockers and diuretics work best in African Americans. If you're noticing that you're a little mildly short of breath, or they're going to hear fluid in your lungs, if you're starting to develop heart failure, they're going to see some of that swelling. They're going to order an echo. You need to go to a cardiologist and get your heart looked into. We need to take care of and be in charge of our health. If we're not going to do that, then we're always going to have these issues and problems for sure.
And these webinars are part of that series that Reverend Allen has been so passionate about, making sure that we start to educate ourselves and know the signs and know the warnings. And we appreciate you being here and helping us. And we will continue to spread the word and make sure that people understand that your health, you have to take care of yourself first.
You do.
You have to do better.
And snoring is an issue. If you snore, you need to have that taken care of. Something as benign as snoring. Sharon's looking at somebody. If you snore, you got to take care of that. My husband had an aunt who died because she did not take care of her snoring. You know what she had? She had pulmonary hypertension, atrial fibrillation from long time untreated snoring. Something as benign as snoring is an issue because you're getting low oxygen levels in your sleep for 8 to 10 hours, can cause problems. Yeah, I'm talking to you, Rev. You need to go to your primary care doctor who can order a sleep study, or go to a pulmonologist, a lung doctor to take care of that.
Twice a year, I go to the doctors. I get a full workup, everything.
Does he know you're snoring?
Yeah. I mean, listen, when I'm tired, I snore, but so does some other people in my house.
If I'm tired, I snore too, but you can't snore every night.
I don't believe that's an every night thing.
Oh, it's not?
No.
I might have to record you.
He's looking at you like, really?
It's okay.
You see what happened when you got medical person in your family?
But you know what? And I'm thankful. And I'm thankful because this type of stuff is what needs to get out into the public. We're hoping that more people will watch these webinars, even though they're not on them now. They'll be able to go back and reference them. I think that if there's, let me ask you this, Dee, is there some type of charts, medical stuff that we can start getting to put in the church as part of this proactiveness that we can be able to pass on to our congregants and those that come into the sanctuary?
Yeah, there's booklets, but you know, I've been thinking about starting a consultating thing. You know, people ask me about their medical problems all the time. And it's difficult when you're reading a booklet to try and put it all together. Does that make sense? A lot of times you need to speak to someone who could, almost like a case manager, and insurance companies have case managers who are supposed to be reaching out and calling patients to try and guide them. But I think it's different. A lot of times you need to sit down and you need to talk to someone and go through all their meds, go through all their history, and make sure that they're on the right path. We can give them booklets, but it's still kind of disjointed. Does that make sense?
Yeah, I think that one of the things you and I had talked about was actually coming in and doing this type of lecture at the church and hoping to follow up with maybe some actual hands-on, because several years ago we were able to get Overlook to come down and do the blood pressure screening. We did diabetes. We did several different things, and now because of COVID, it's kind of a little bit out of sort. But hopefully, in the near future, we'll be able to get back to those actual types of clinics that we could do there at the church, which would encompass some of the same things that you talked about there. A variation of people to do that. So again, we're reaching out for this point to try to get it out there as much as possible until we can do the actual physical clinics, whether it be through Overlook or Morristown Memorial. I think that that's important, that the church take this stand and be part of the proactiveness. And again, we're being proactive when it comes to the vaccines. We're talking about it, encouraging people to do that. And hopefully more people are doing that. I have actually a call tomorrow with people from Homeland Security, the governor's office, several people talking about how we can improve getting the vaccine out to the African Americans, the seniors, so forth and so on. So I'm very proactive about this. I really want to see us take this, once this pandemic is out of the way, and move it to some actual clinics and some actual things that we can invite people in to do.
Right. And I think, Dee, your suggestion for actually having someone go through the medicines of some people and helping them to really guide and make sure they're asking the appropriate questions. Because another thing that I have found, especially with dealing with my dad, is the doctors will prescribe medicines and not know what the other doctor has prescribed. And then he'll have like two things that do the same thing.
Yeah, and he's taking both.
Exactly. And I'm like, wait a minute, are you're over medicating him?
Yeah.
Or they're not looking at his charts appropriately to see how all these medicines are interacting with each other.
Right. And they're having side effects.
Mm-hmm.
Well, Connie, I think the whole problem has existed for a long time, as Deb says. You know, when we go to a doctor, not saying that all Caucasian doctors are not going to take care of you, but they just prescribe anything. They'll say, hey, take this. If you don't feel better, come back. But it's good to sit down with someone who understands your culture,
right, and
help you understand what you're going through and how you need to treat it. You need a good platform.
Right.
Totally.
It was an idea I got going. I don't know. I just need to get it off the ground.
No, I think it's definitely a good idea. And I think people would definitely participate if you had something like that, because you can easily, they'll probably come in with a bag of pills, because that's what my dad used to do. He goes to the doctor, he puts all his pills in a bag and go. And I'm like, okay, no, this is not going to work. Let's get a printout. But yeah, I think our elderly people need that, or their family members need that.
So how, I know you said that, but how can we help? at the church to do exactly what you just said, because I think people will come if we can get some people of your magnitude or understanding to come in and set up. And again, I don't know how long, but if they bring their medicine or list of their medicines in to do that, I think that that's a very now thing, because people are on a multitude of different medications, and we already know one medication, it cures this, but it gives you 50 other things to make it wrong. And so I think in the long run, if we can start to do that, I think we can start to change some bad thinking that's been throughout history with African American people not going to the doctor, not being honest with the doctor, shrugging off a lot of things. You know, my rule is if I feel bad, you know, 2 days in a row, I know something's wrong with me. So I'm going to try to go to the doctor, make an appointment to do that. But a lot of people don't do that. And of course, we have to encourage them to do that. And soon, hopefully within the next month, Alice is in the insurance area. We're going to try to get her to come and talk about the insurance industry, talk about the multitude of different insurances that are out there. You know, we're in a society now where people think it's okay to go, you know, somebody dies, go have a FundMe page instead of having insurance that is available and affordable, that they don't have to go through that kind of stuff. I'm not sure, you know, how my mother did it, but all of us had a policy and she paid that $10 a month or whatever it was to make sure until we got on our own. I just think that we have to do better. And the way we do better is to educate our people and what they need to know and how they need to know it and what they need to do. There's a lot of information out there. It's just, we got to get it to them.
Agreed.
Any other questions you guys have? Otherwise, if we, you know, after today, Dee's going into consulting, she's going to start charging us.
Oh, God.
Well, again, we want to thank you. Your information is invaluable. There's no price on being able to have somebody within our congregation to be able to come and talk to us and give us this type of information. I hope those that see it later on will value it as we have those that have been on this. I think our biggest problem is trying to get people to connect directly. It's good to listen to something later, and I say this, but it's nothing like being able to ask you a question or whoever our lecturer is about the topic directly. And that's where people miss out on opportunity to ask the questions. If they got something going on, they don't think that their doctor's giving them the proper care, or they're on 10 different medications or whatever the case may be. These are the opportunities that we try to give to people, why we bring people on in our webinar series to talk about this type of stuff. So again, thank you so much. Appreciate it. You know, I try to make sure I'm healthy because you're not in church to take care of me if I fall out. So
I'm waiting for the COVID numbers to go down.
Oh, okay. But again, and I think one of the things that I do want to do to get you to do or help me to organize again is to renew our CPR training for our ushers and or others that want to do it in the church. We never know who we're going to perform it on. So it's good to know that and have it so that anybody that wants to take that training can come in, and especially while we're at service or wherever they may be on their jobs in their home, to be certified in the CPR. I think that that's a must thing that we have to do. And the other thing is, and we don't have it in a church, but we need to get it is that automatic
AED.
yeah, and get that in there. So that's something we need to do.
Oh yeah.
ASAP to make sure we have it there. And then it's self-training, but it's good to go over that with whomever is there to be able to make sure that they know how to use it. I mean, it's almost, fail proof, but you still got to have people to hook up and put the pads in the right place and all that kind of stuff like that. So that's one of the things that we need to do. Anybody else before we close out? Who? Connie?
Nope, I was going to say thanks again, Dee. Wonderful job as always. Look forward. We are starting to think about our next sessions. As Pastor said, we most likely will be focusing on insurance because it sounds like we definitely need that. So look for us to start planning that session. And when we put that out there, please attend, please share with your friends and have everybody who can come on and learn some information.
Thanks, Dee.
Everybody.
Thanks, Mom.
Thank you.
Make sure you hit,
Bye.
I know, this is hit the save to cloud.
I have to hit the save the cloud. Where's that?
Yeah, the recording is gonna come up. Ask you about the recording.
When I stop the recording, it's going to say
Yes.
save the cloud.
Stop. Yeah.
All right, stop the recording. Do you want to stop the cloud recording? Yes.
Yeah, it's gonna come up and ask you when